So now I invite Dr. Rashmi, who is associate professor at AIMS Devgar, for her talk on disc dissection by OCT, coming to the glaucoma part. This OCT is again giving lot of information regarding the disc analysis, and when it correlates well with your clinical finding, it enhances the chances and enhances the chances of correct diagnosis. So, Dr. Rashmi, please.
Thank you, sir, for giving me this opportunity. So my topic is dissection by OCT. So one declaration I have to make in my presentation. I have used brand name of some OCTs, but मुझे किसी ने कुछ दिया नहीं है. I have no financial interest at all. So when we talk of disc evaluation, what are the diseases which come into our mind? Primarily glaucoma. It's an optic nerve head neuropathy, and some diseases which are primarily linked to optic nerve head, that is ischemic or demyelinating or inflammatory diseases, or secondly affecting the optic nerve head, that is disc edema. So disc imaging, as far as investigating modality, has not been incorporated per se in neuro-ophthalmic workup as a primary modality, but it has been able to make its role, create its space as far as the management and diagnosis of glaucoma is concerned. So I will be talking about basically use of OCT in glaucoma. So disc imaging, we have a number of tools, but the most common tool which is being used worldwide is optical coherence tomography. Optical coherence tomography, as has been explained by my previous speaker, is a non-invasive in vivo cross-sectional imaging technology and is analog of ultrasound imaging. It generates high resolution cross-sectional 2D and now even 3D images for internal tissue microstructures, and has seen evolution since its inception in 1991 to its introduction in 1996 to the current state. And the basic evolution is in speed scan, which has made improvement in resolution, better penetration, repeatability and reproducibility of the data, and even the area of scan. And even the spectral domain OCT has undergone many modifications like adaptive optics or incorporation of visible light optics. And the just previous speaker has told about OCT angiography, which is now delineating the vascular pathologies as well. So spectral domain instruments are available commercially. You have heard Cirrus or Spectralis, RTView from multiple manufacturers. Resolution, scan, acquisition rate, and measurement across these devices are generally not interchangeable, but their ability to detect glaucoma is very similar. So OCT scan from one instrument needs to be compared with the same instrument as well. Apples cannot be compared with oranges. Okay. So as far as glaucoma continuum is concerned, OCT holds its place even before we get the visual field changes. That is pre-perimetric glaucoma. What does this OCT do? It objectively measures the thickness of each retinal layer and does a topographical analysis. And it basically measures the neural structures, be it retinal nerve fiber layer, optic nerve head, or ganglion cell complex. I will be dealing with the three parameters one by one. Coming to the first one, retinal nerve fiber layer thickness parameter. It is generally done by using a 3.4 millimeter circular scan centered on the optic disc, which takes subsequent scans with different speeds depending upon the machine. And this is the most reproducible parameter. It gives a deviation map, it gives a thickness map. But the point to be noted is color coding. In thickness map, the red is thicker nerve fiber. But in deviation map, the red means it is significantly lower than as compared to the normative database. So while evaluating the thickness as well as deviation map, this color coding needs to be kept in mind. Second is Tisnit graph. That is the scanning done from temporal to the, and again reaching to the temporal when it is plotted in a graph. And the thickness parameters are even represented by quadrants, clock hours, or sectoral graph. So all these parameters, sub-parameters rather, in RNFL analysis needs to be taken care of. How do we use them? So this is a case, 40-year-old male with pre-perimetric glaucoma. You can see inferior temporal nerve fiber defect in red flea light corresponding well with thickness map, with deviation map, and also with the Tisnit graph and the sectoral. So it's all good. All are collaborating. So initially there was no different change in the visual field, and gradually visual field difference appeared. So what about this case? It's a perimetric glaucoma patient. There is change in the optic nerve inferotemporal part, but that is not been depicted in the sectoral as well as clock hours map. But this is very well depicted in deviation as well as thickness map and is corroborating with the Tisnit graph. So we have to correlate the subparameters as well. Now coming to the macular parameters, spectral domain OCT uses 6 into 6 millimeter macular cube, while the swept source OCT uses a wider field, that is 12 into 9 millimeter scan, and the measurement given is in two forms: GCC, ganglion cell complex, or GCA or GCIPL. Different machines have different inbuilt formulas for calculating them. Now, minimum GCIPL is the best parameter for discriminating early glaucoma, while inferotemporal GCIPL is best parameter for myopic pre-perimetric glaucoma for healthy myopic eyes. As said earlier, swept source OCT with a larger macular scan than the spectral domain has better diagnostic performance because we get an overview what is happening in the RNFL, neuroretinal rim, as well as the ganglion cell. As you can see in this graph, 48-year female with pre-perimetric glaucoma has a corresponding corresponding lesions in the quadrant map as well as in the deviation map. That was not depicted earlier in the visual field, but gradually she developed this defect after 1 year. So coming to the optic nerve head parameters, it is basically the quantitative analysis of the neuroretinal rim, where we measure rim area, vertical rim thickness, vertical CD ratio. But due to the variable orientation of the rim tissue to optic nerve head, newer parameters like Bruch's membrane opening, minimal rim width, and 3D and RT has been introduced in SDOCT for better ability to detect this glaucoma. So what is this why these algorithms are there in this machine? Basically, how do we get the size of the disc and how do we calculate the size of the cup? So taking the Bruch's membrane opening as the as one point for the optic disc measurement, and then then taking it as a reference plane. Different machines have different cutoff levels above which the cup values are calculated. Cirrus has 200 microns above the RP, RT has 150 micron, and 3D OCT has 120 microns. But there are some situations when this disc margin is not very well delineated, like high myopia, then the Cirrus or spectralis OCT calculates the BMO MRW, that is minimum distance between the BMO and ILM. And this is said to be reference plane independent to overcome the structural abnormalities in certain diseases. This is the cross-sectional as well as longitudinal diagram, how this BMO MRW is calculated. This is the Bruch's membrane opening, and this is the minimum distance from the ILM, and this is the minimum rim width. This is being shown in the cross-sectional image as well. So again, a left eye of a 43-year-old female with pre-perimetric glaucoma. Here, both the Tisnit graph of BMO MRW as well as RNFL thickness are correlating. So there is no problem in this case. But what about this? This is abnormally looking disc, but there is no RNFL changes in clinical examination as well as red free light, but you are getting some red areas in deviation map as well as Tisnit graph, quadrant map. But when you do an BMO MRW, this patient is absolutely within normal limit. So these are the situations when these parameters come to our rescue. Otherwise, this patient would have been undergone management for glaucoma for rest of his life. So NRR parameters can be complementary to RNFL or macular GCIPL in detecting early glaucomatous change with improved specificity. Again, a 40-year-old male with pre-perimetric glaucoma. What do you see here? You can see changes in deviation map, thickness map, but the quadrant maps are and the sectoral maps are absolutely normal, but you are getting changes in RNFL Tisnit graph as well as neuroretinal rim thickness graph. So again, this is corroborating with the clinical picture. So this patient is having glaucoma. Other areas what we have to look for in the scan is patient details, because after all, the patient details needs to be compared with the normative database. So so age and ethnicity as well as refractive status of patient is important. Image quality, every machine has different signal strength, and for a spectral domain OCT, a signal strength of less than 6, the image should be discarded. After 10, the image quality needs to be more than 6. And spectralis, every machine has its own inbuilt or fed data for image quality, and that should be taken care of. Then another point, tomographic landmarks needs to be taken care whether the Brooks membrane opening has been rightly demarcated or not. Otherwise, whole of the calculation will go haywire. And this is the disk and NFL parameters, which has been shown in this graph. Every machine has its own database with which the data of the patient is compared and is given a red or the green or the yellow color depending upon the amount of deviation from the normative database. Coming to the macular scan, again the patient data, signal strength, thickness map, deviation map, macular parameters, and horizontal B scan. All parameters needs to be rechecked while interpreting the map. There is another software in these machines which is called GPA. As we have in Humphrey's visual field, there is a guided progression analysis for individual parameters as well as that can be event based or trend based, taking into account the age accountability of the loss of RNFL or the ganglion cell. This is a map which is denoting the average RNFL thickness, superior RNFL loss, or the inferior RNFL loss in a decreasing trend, and different color coding denoting progression. Again, this nerve fiber layer is when compared with the macular ganglion cell. This is corroborating with the Humphrey's visual field analyzer as well. Similar is the analysis with Brooks membrane minimal rim width, and this is also showing progression with quantitative measurement, whether the deviation is significant or not. New advancement in the imaging modalities of the disc is imaging of the lamina cribrosa with the invent of swept source OCT, which is now known to have potential to serve as biomarkers for the glaucoma progression. And the main structures which we look for in cases of glaucoma is the microstructures of the curvature of the lamina cribrosa as well as the thickness. All the three parameters are known to have differences as compared to the normal patients in the lamina cribrosa, and these are used as comparison tools for the progression of the glaucoma. Functional OCT, as has been described by the sir, is done by OCT angiography, and that depicts the vascular dysfunction in the optic nerve head, and it may contribute to the development and progression of glaucoma. And this is basically useful when we have inconclusive investigation reports from OCT or other things in cases of glaucoma, when the structure of the optic nerve is not so well delineated to depict a real picture when these investigations come into our rescue. As you can see, there is inferior nerve fiber layer defect, which is depicted by decrease in vessel density in this place, and this is corroborating the visual field defects. And in this case, where the situation was very dicey, it looks there is segmentation error, which is not reliable, but in OCT angiography, there is decrease in vascular density, so there is definitive glaucoma in this patient. Again, when we use a machine, we have to be aware of the limitations. There is a limitation called floor effect, because in advanced glaucoma, there is a point after which no further structural damage can be depicted. And we have to distinguish glaucoma from red disease, that is false positive, and green disease, that is false negative. And the main source of errors can be because of OCT mistakenly takes an area as abnormal, or when we ignore the sensitivity, specificity of the OCT. And the main problem is the normative database included in the OCT do not include extremes of age, has no consideration of axial length, has nothing to do with extremes of refractive errors, and there is no correction factor for that. So these patients need special consideration. There are certain artifacts like motion artifacts, as can be depicted by wavy lines in the scans, and these are generally, to take care of these, high scan OCTs are developed, and there are techniques to track the eyes, but still they exist. Blink artifacts, when these data needs to be discarded, and you have to go for repeat testing. Media opacity, as you can see, vitreous opacity can get incorporated in the measurements when the whole of the calculations is fallacious. Myopia is special situation which has ocular magnification effects, and there can be true retinal thinning as well. So these patients need special care while interpreting these reports. Vitreoretinal interface problem like VMT can cause false positive green disease. This can miss focal changes because of retinal thinning. And patient-related factors again include some retinal edema or optic nerve head abnormalities. There can be instrument-related factors like poor image quality, poor OCT device performance, inaccurate optic disc delineation as seen in this picture. Or there can be segmentation error when the OCT machine was not able to identify the each structure properly. There can be operator related artifacts when the patient data was not fed properly, OCT lens was not cleared, OCT scan circle was not properly placed as you can see in left eye of this place, and when the scan was repeated, the scan was absolutely normal. An incorrect axial alignment of the OCT image, which results when the area of focus is not within the frame. The patient head or chin rest is not properly placed. So these minute points needs to be taken care of while interpreting the reports. So in conclusion, I could say OCT for optic disc analysis remains a dynamic and evolving imaging modality with better introduction of software algorithms, and using all structural parameters in combination with one another is most effective. And clinicians should be aware of OCT limitations and possible scan artifacts, and clinical decisions should not be driven by OCT results alone. Thank you so much.
Thank you, Dr. Rashmi. That was very informative talk on OCT in use of OCT in glaucoma. Just wanted to know, say that if there are some patient where it is not possible to do perimetry, then in those situations, would you advise that glaucoma treatment can be just started on the basis of OCT
It's
only?
better to have something than nothing. It's better to try to identify by the help of OCT as well, and not depending on the visual fields only.